This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here.
And I'm Dr. Ilara. Today we're looking at a fascinating new study from the Journal of Stroke and Cerebrovascular Diseases, published in 2026. It's a comparative study titled Endoscopic Evacuation versus Stereotactic Aspiration for the Treatment of Supratentorial Intracerebral Hematoma.
This is a timely topic. While the neurosurgical community has shifted toward minimally invasive surgery, or MIS, for intracerebral hematomas, we often debate which MIS technique is superior. This study specifically pits endoscopic surgery, which we'll call ES, against stereotactic aspiration, or SA.
Exactly. The researchers focused on something we talk about a lot in the ICU, perihematomal edema, or PHE. They wanted to see if the surgical technique influenced the volume of edema, and if that, in turn, affected long-term functional dependence.
Let's get into the methodology. They looked at 118 patients over a 9-year period at a single center. 62 underwent ES, and 56 underwent SA. Ilara, walk us through the procedural differences as described in the paper.
Of course. For the ES group, they used a transparent sheath and performed evacuation under direct vision with suction and irrigation. The median time from onset to surgery was about 9 hours. For the SA group, it was a CT-guided procedure using a 10 French Nelaton catheter and a single aspiration. Their median time to surgery was slightly longer at 10 hours, but not significantly different.
Now, the results regarding the evacuation rate were quite striking.
They really were. The evacuation rate for the endoscopic group was significantly higher, 89.0% compared to only 54% in the stereotactic aspiration group. That's a p-value of less than 0.001. Consequently, the residual hematoma volume was much smaller in the ES group, a median of 4.3 milliliters versus 14.1 milliliters in the SA group.
And this is where the deep dive of the study begins. The authors hypothesized that the amount of blood left behind, the residual hematoma, is the primary driver of secondary brain injury through perihematomal edema. What did they find regarding the PHE volumes?
On postoperative day 3, the PHE volume was significantly smaller in the ES group, 16.9 milliliters compared to 23.4 milliliters in the SA group. They also looked at the change in PHE from the preoperative state to day 3. In the endoscopic group, the edema only increased by 4.6 milliliters, whereas in the aspiration group, it jumped by 8.6 milliliters.
That's a crucial distinction for the residents listening. The study performed a multivariate analysis which showed that residual hematoma volume was the only independent factor associated with day 3 PHE volume. So the more blood you leave behind, the more edema you're likely to deal with in those critical first 72 hours.
And the study takes it one step further by linking that edema to patient outcomes. They evaluated the patients at 6 months using the Modified Rankin Scale, or MRS. They found that day 3 PHE volume was an independent predictor of core functional outcome, defined as an MRS of 4 to 6.
Now, let's be nuanced here. Despite the better evacuation rates and lower edema in the ES group, did the study show a massive difference in the 6-month clinical outcomes between the two surgical groups?
Interestingly, the distribution of favorable outcomes, MRS 0 to 3, was fairly similar. It was 32.3% for the endoscopic group and 30.4% for the stereotactic aspiration group. There was no statistically significant difference in the long-term functional dependence between these two specific cohorts in this study.
That's an important takeaway. While endoscopic surgery is clearly superior at clearing the clot and reducing early perihematomal edema, both techniques remain viable minimally invasive options. However, the data suggests that if our goal is to minimize secondary injury from edema, the direct visualization and higher clearance of the endoscope give us a distinct physiological advantage.
It definitely highlights that for residents and fellows, mastering the endoscope might be key to managing the inflammatory cascade that follows an ICU. The paper concludes that ES is more effective than SA in reducing residual hematoma, which directly limits the progression of PHE.
Great summary, Ilara. To our listeners, remember, the goal of MIS in ICH isn't just to remove the pressure of the clot, but to mitigate the chemical and inflammatory toll of the residual blood. This paper gives us strong evidence that more is better when it comes to evacuation percentage.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you next time.